Afternoon. Welcome to the Health and Social Care Select Committee for our session this afternoon, looking at the implications of a possible no-deal Brexit on health and social care. For those following from outside the room, could I ask you to introduce yourself, starting with yourself, Professor Hervey?
I'm Professor Tamara Hervey. I'm the Jean Monnet Professor of European Union Law at the University of Sheffield, and I'm also acting as a specialist advisor to this committee.
Thank you.
I'm Saffron Caudry. I'm Deputy Chief Executive of NHS Providers, and we are the membership body for all NHS trusts covering acute hospitals, mental health trusts, community services and ambulances. And we have 100% of trusts in membership.
Thank you.
And I'm Dr. Mark Lloyd-Davis. I work for Johnson & Johnson covering medical devices for Europe, Middle East and Africa.
I'm Mike Thompson. I'm Chief Executive of the Association of British Pharmaceutical Industry, and we represent members who supply sort of over 80% of the medicines to the NHS and supply all of the global medicines which are in the pipeline to come through, or almost all of them. And with our sister agency, the BIA, we've made the submission to you.
Thank you.
Hello, I'm Martin Saw, Executive Director of the Healthcare Distribution Association, representing the larger wholesalers and distributors who distribute medicines on average twice a day to all hospitals, pharmacies and doctors, and get paid for it by the NHS. Thank you.
Thank you very much. Well, just to start us off, I wonder, Professor Hervey, whether you could set out the legal context and background about what no deal means in practice.
Thank you, Sarah. I'll do my best. So currently, health and social care in the UK and all of the UK, including its devolved region nations, is deeply integrated with the European Union. So everything to do with the way that, pretty much everything that to do with the way that we organise health and social care has something to do with our membership of the European Union. The people who work in health and social care, the products that we use, the structures that we use, safety, all of those kinds of things, research, all of those kinds of things. And all of that integration is underpinned by European Union law and the way that European Union law takes effect in our domestic legal system. If we leave the EU with an agreement, a withdrawal agreement, then that will be the legal basis of the way in which we leave the EU. If we leave the EU without that agreement, there'll be no clear legal basis on which the UK leaves the EU. That will mean that from the point of view of the European Union, the UK will overnight become a third country external to the EU, and that will mean that UK nationals who are in EU countries, either visiting or residing there, will be treated as third country nationals in EU law. Those people who have long-term residence status have some rights in EU law, including to basic health care, but everybody else has no rights in EU law. So let's say a pensioner who retired to Spain a couple of years ago will have to rely on Spanish law to know what their entitlements are to health care. That becomes immediately much more confusing and difficult to understand. All of the administrative systems that support interaction between the UK and the EU will cease to be functioning because we don't have that legal underpinning for those administrative systems. In terms of EU nationals in the UK or EU products coming into the UK, whether there's a deal or not, the European Union Withdrawal Act seeks to secure continuity. So we know that the EU Withdrawal Act will mean that products can be recognised that are coming into the UK, formally speaking. What we don't know is about the practicalities of how those products will reach the UK, because anything that has to do with a cross-border element can't be unilaterally legislated for in the UK. It has to be agreed with the EU, and of course no deal means no agreement.
Thank you. We're going to start this afternoon's session looking at the implications of the pharmaceutical industry and medical devices. And Ben's going to kick off the questioning.
Yeah. Could I ask, actually, the four witnesses responsible for pharmaceuticals, medical devices, but also the provision of healthcare, leading on from the scenario that Professor Hervey's just laid out of the UK becoming a third country, what is it in that scenario that keeps you awake at night? If you could summarise your worst nightmares.
So I should sort of kick off. So I think what Professor Hervey has laid out explains why we need a deal. And we absolutely need an implementation period as well. So our main concern is to ensure that we can continue to deliver the medicines that patients need, both here and on the continent, through this period. So that is the thing that we have been working the hardest to do.
Maybe to build on that, so indeed a deal is critical. So our biggest concern is that our company uses the British Standards Institute to CE mark, as the old kite mark, the vast majority of our portfolio and a lot of the industry's portfolio. And if we leave the EU without a deal, they will not be able to do that.
As a third industry supplier, sorry, I've got a bit of a cold. As a third industry supplier, what keeps us awake at night is the uncertainty of no deal. Without the medicines, 50% of the medicines on average in most of our depots have been through the EU before they get to the UK warehouses. And this whole integrated supply chain that we rely on was clearly set up after we joined the EU. It's only in the last 20 years that it's been put in place. It's very sophisticated, twice-a-day delivery, almost just in time. We only have 2 or 3 weeks stock normally in a wholesale warehouse, and it's very dependent on supplies coming in when they say they're going to come in. So any challenge to that without an arrangement that makes a frictionless border will mean shocks to the supply chain. So we're worried about shortages, patients not getting medicines, and the huge price rises for the NHS.
And Saffron Cordry is the person responsible for actually taking this stuff and delivering patient care with it. What's your worst nightmare?
So a number of worst nightmares, actually. So I think what we think about are, healthcare is inherently a risky business anyway, and the uncertainty adds to that risk. So workforce supply, a huge issue. We know it's already pressured out there in the NHS. The timing of this is also critical, and the timescales. So I think that there hasn't been sufficient time for national level planning, frankly, and also, although it's speeding up now, and also the timing in terms of coinciding with other pressures across the NHS. We're approaching winter. We know that's a hugely pressurised time for trusts on the front line. We also know that trusts are doing their damnedest to meet their efficiency targets. They're going to have to take their senior time away from that and focus on planning for a no-deal Brexit. That doesn't put them in the best position. And I think that one of the things, colleagues here have talked about supply chain management. That is fundamental. Things like getting food into trusts is an issue. So we need to think about all of those elements. It's not just about medical devices. It's not just about pharmacy. It's about those broader issues as well. When someone is an inpatient, they are in the care of a hospital or a mental health trust. They need to be fed and watered.
Perhaps going back to the 3 gentlemen witnesses, can you give me some examples that would be meaningful to people out there, patients out there who rely on medicines or medical equipment, of things that might run dry, that there might be a shortage of, that we should be really worried about?
Well, I think if we look at the scale of this, there's 46 million packs of medicines a month leave the UK for the continent, and there's 37 million packs of medicines a month come back the other way. So we have a scale factor here. Also, if we look at the latest medicines which we are producing, they're almost all biologics and they require cold chain storage. So that means they've got to be kept between 2 and 8 degrees from when they're produced to when they actually get to a patient. There are no cold chain facilities at the border ports, so that's why we rely on real frictionless trade to be able to move medicines quickly, and those are the things which clearly will give us challenges in the event of challenges at the border.
From a medical device perspective, our number one priority, of course, is to continue that supply of medical devices to patients and clinicians. But, for example, stitches, which are a central part of all medical practice and surgery, our company, Johnson & Johnson, supplies 69% of all stitches in the NHS, and they are CE marked by the British Standards Institute. So if they're not able to undertake that process, we don't have the authorisation to supply those stitches.
Domestically or anywhere?
Within, in fact, the entire European Union and also into the UK.
Nothing specific I would want to say other than if you've read about the shortage of EpiPens, methadone in the past, it always can rise to the surface very quickly, any shortage, because of the just-in-time nature. I mean, I have a weekly list here of where medicines haven't been delivered to our warehouses, and this is 13 pages long, and that's quite normal. We work with the Department of Health to manage supply through the NHS where we can, because we can find product around the UK. So I'm just suggesting that the system would become very unbalanced very quickly if there's a shortage in any particular area.
So, I mean, how do you respond? I was on the radio this morning with Julia Hartley-Brewer, who is a well-known Brexiteer, and actually said she would rather like a no-deal Brexit, because none of this is going to happen. It's all scaremongering. We import stuff from the United States. The continental Europeans want to sell us their stuff, so there isn't really a problem here. How do you respond to that kind of claim that there's not a problem?
So, well, I think that we would be all really abnegating our responsibility if we didn't plan for every scenario, because it's absolutely critical. So we might be saying there could be no problem, but fundamentally we have to plan for that problem, whatever happens. So I think that, we know that the supply chain, the workforce, all of the issues across the NHS are so interdependent.
But why would that dry up in a no-deal Brexit scenario? Just explain that to me in practical terms. Why would the stuff not come in?
In my industry, then very simplistically, we have an integrated European supply chain. We have a supply chain which manages the Americans, and there's one which manages the rest of the world. So for any medicine that's brought in, it needs to be brought in under the licence that we have, which is a European licence. So to move outside of that requires a lot of work that has to be done. At the moment, everything has to come in through that way. So if we suddenly find that we're not able to get our medicines through the borders, then we have real challenges, and therefore we have to be doing work now to prepare for that eventuality, to ensure that, should that happen, we have a way of getting the medicines to the patients.
And the same for devices?
Well, it's similar. So in the examples I was giving, there are solutions without consequences. So a solution is that companies that use the BSI to certify will start transferring their files to notified bodies within the European Union, so they can do the CE marking, but this has a multi-million pound price tag associated with it. And also those other notified bodies ask different types of questions, which has a risk of delay of the product being authorised in time.
Now, that takes me on nicely to contingency planning, because last time you were here, or some of you were here, we heard that AstraZeneca had already invested £40 million on the continent. The evidence from your organisation, Mr Thompson, to the committee this time lists a whole string of pharmaceutical companies. AstraZeneca, 40 million in Sweden, GlaxoSmithKline, 70 million in other EU countries, Lilly have gone to Spain, etc., etc. Is it possible to put a figure on how much you've already had to spend in terms of moving stuff to the continent because of contingency for a no-deal scenario?
Well, I think we can assume that it runs into hundreds of millions of pounds across the industry.
Hundreds of millions of pounds.
I think we've tried not to put the focus on the money. We're trying to put the focus on the patient, because the biggest issue is around patients not getting their medicines. This is not a situation where if we manage to get 80% of the medicines there, that's a good effort and it's okay. Every single patient is reliant on their medicine, so we have to do that for every single patient. So that's the challenge that we're facing.
And if we get a deal which is the kind of deal that you described that you would be your preferred option last time, which was regulatory alignment, close to the single market customs union, would that investment come back? Would that work come back here, or is that gone for good?
Well, I think the jobs that have gone for good. Right? But these are relatively small numbers in the scale of things at this moment in time. I think what's encouraging is that politicians of all parties have supported in the UK continued medicines cooperation as the outcome that everybody is looking for. It makes absolutely no sense, for instance, if we think about things like infectious disease control. At the moment we have one pan-European database where we put all our information in, and we can support each other by picking up trends. It doesn't make any sense for us to have two separate databases. The same with pharmacovigilance. You know, Europe relies on 30% of the adverse events being picked up by British doctors. So we're all in this together, and I think that's recognised. The challenge has been that the EU has failed to give any signal about what sort of cooperation they would like until some substantive issues have been resolved. And therefore we're getting very close to something which could be very difficult indeed, and we don't know exactly what they would want. But I think there's absolute consistency from everybody to say that continued cooperation is what is in the best interest of patients and public health.
Where are we now on stockpiling?
Well, the Secretary of State wrote to everybody asking them to build an extra 6 weeks stock, which we have been doing. The department has surveyed our members and I think are very pleased indeed with what we've been able to do. I think that's because actually a lot of people had started in advance of that request. I mean, I wrote out to my members in December last year and asked them to start planning for no deal, because I think our industry has the longest supply chains of any industry. So we typically can take up to a year to establish a supply chain for a new medicine. So you need to remember we're now less than 6 months away from potentially a hard Brexit. If we hadn't done the work now, it would already be too late. So companies have done the work. We, I think, have had a very good response to it, but we have always said that stockpiling will in itself not be enough to protect British patients. We will need to consider other things as well.
Martin Sawyer wants to come in.
Sorry, I can just add to that, but we have no sight of where the gaps are in that stockpiling. So us receiving medicines, and we have pre-wholesalers in our membership who are going to stockpile with Mike's members. We've no view on where the gaps are yet, and there's little time to build up new supply lines for those gaps. So it isn't going to be the be-all and end-all, I'm sure.
I think it's worth adding to that a letter has also gone out to the NHS as providers of services, explicitly saying not to stockpile drugs. So, it's on the industry side that is being managed, and the NHS has been told not to stockpile drugs. And of course, if we don't have that oversight of what's happening nationally and then what the supply is going to be into local trusts and into local pharmacies, etc., then that is a substantial concern as well. So just worth bearing in mind that there is a separation between what's happening nationally and locally.
What do you think about the 6 week figure? I mean, where's that come from?
Well, we in the medical device side, we stockpile to 4 weeks because we've been given the direction that the routes that we use, which is a Berger to Hull and then air transportation into Doncaster Airport in East Midlands, that's sufficient in terms of they don't see bottlenecks appearing there. So 4 weeks has been the advice we've been given. So we follow to that.
That's been government advice that we've been told to work.
And do you think it's enough? I mean, if we see some of the problems that have been predicted at Dover, is 6 weeks going to be enough?
I think the problem is actually at Calais. We need the infrastructure to come backwards and forwards, because most medicines coming through Dover and Folkestone, and we don't know how France is going to or EU is going to treat the UK. If we're treated as a third country, the boats and lorries will be just tied up in Calais. They won't come back because it's a closed loop system using.
Do you think we should be aiming for a stockpiling for longer than 6 weeks?
We haven't seen the basis on which that 6 weeks has been developed, so we can't answer.
You haven't seen the basis
question.
on which it's been developed. Mr. Thompson, what do you think the basis is?
Well, I think we have to rely on what the Border Force advised government is the requirement. A number of my members have stockpiled for more than 6 weeks because those are standard buffer amounts that they would have. But as I said in my evidence to the BrExit Select Committee, I think that is a key assumption that we're making. However, stockpiling, I think we have always been clear, stockpiling will not be enough.
Just explain that.
And there are some other things that we need to do. Well, for instance, we have some medicines, right? So if we take, say, a latest medicine where we take a bit of DNA out of a patient, it goes to the continent, they modify it, they bring it back, and they put it back into the patient. You cannot stockpile a person's DNA. So we need to have some routes, which may be a fast-track route. It could be airlifting. It could be in extremis opening us other supply lines. So, for instance, we could decide that we would look at America and look to bring some product in from America. But we need to recognise that that product is currently signed off to a completely different licence by the FDA. So there'll be a lot of preparatory work that would need to be done to ensure that we were able to bring American product in And the same way for the generics industry, there are some Indian suppliers who currently don't supply the UK but have licenses. Again, you could do some investigation to bring some extra stock in there. So I think those are things which, I have to say this sector, I think, is more advanced than any other sector in terms of the planning that's going on, which is needed because of the long-term supply chains that we have. But I do think that we will need to be looking at other things as well to guarantee that we do the best that we can.
Okay, now I know lots of colleagues want to come in. Can I just press on a point of clarification before I bring other colleagues in? You've mentioned, Mr. Thompson, that it's already hundreds of millions that's been invested to date. Does that include things like actually planning for complex warehousing, including refrigerated warehousing and so forth, that you say is lacking? And what does it cover so far, and what do you anticipate is down the track in terms of total costs?
Well, I think we know that there's not enough cold chain warehousing in the UK today to cover the stockpiles we've been asked to build.
Yes.
So there is a request into government to support the building of additional cold chain supply. There's enough ambient warehouses, we believe, but there's not enough cold chain.
But unfortunately, there's a division in the House.
Yeah.
We're just going to have to suspend while members go down to vote. But can I ask, when we come back, it would be really helpful to have some idea about where the costs are, as you say, now and in future, and including for devices, perhaps from yourself, Dr. Davis, if that's okay. But we will just suspend for a short period.
Is currently suspended. The proceeding is currently suspended.
Because we'll start, because I'm very keen that we should have on record as much as we can from you this afternoon. And I understand that several of you have to leave at 4 o'clock. Is that correct? 4:30. 4:30, right. Okay. So, as we were leaving, just to recap, I was asking Mike Thompson if he could just set out for us in a little bit more detail the costs that the industry faces as a whole. And then I was hoping to come on to yourself, Dr. Davis, to hear about the situation for Johnson & Johnson. So, as I say,
yes.
you mentioned that it was hundreds of millions already.
Yes.
What do you anticipate to be the total cost that we're already committed to, given the uncertainty that we face?
So I think it's difficult to put a total number on it because obviously individual companies have had their own costs. Although Pfizer posted a cost of $100 million actually in their latest quarterly accounts. So I think people will start to see things being posted in companies' accounts. I said, obviously there is the cost of stockpiling, which is a very significant cost. Secondly, companies have had to build duplicate testing laboratories on the continent. That doesn't sound very much. As I always say to people, when we do quality control, this is not somebody with a clipboard at the end of the line. This is building a laboratory. You take a medicine, you have to analyse it to make sure the active is exactly there in the quantity it's meant to be, and the medicine is working in the way that it should. And that's why patients can be really reassured that every time a medicine is going to work. So just between GSK and AstraZeneca, they've allocated over £100 million just to build duplicate laboratories on the continent, which is why we've been asking the EU to take the same decision that the UK have taken, which is to say the UK have said we will take medicines which have been manufactured in, say, the continent, we will accept them to come and be used for UK patients, as of course they are today, but in the event of a no deal we will continue to allow that to happen. The EU have not done that, and I think it obviously is disconcerting to companies as to why that hasn't happened. So our request is that they should do that. That has made a huge difference to our ability to supply in the UK.
Thank you, and I'll come back to the point about qualified persons and some of the other complications around that in a minute. But perhaps, as say, Dr. Davis, could you actually talk us through in more detail the situation for Johnson & Johnson?
Sure. So at the moment, our focus has been on increasing warehouse space, hiring additional staff, and also we've increased our transportation capacity by 15%. So the cost of that actually is 1.1 million spend at the moment. The issue I mentioned at the British Standards Institute and whether we have to move to another European Union-based notified body, that the trigger has not yet been pulled on that, but will need to be pulled very soon, and the cost of that will be between 40 to 50 million pounds to do that. We've also calculated that if there were a no-deal scenario between 2019 to 2025, assuming that at some point there would be regulatory divergence. I know the UK government said it would accept the CE mark, it would accept European regulation to begin with, but if there were to be change in rules within the European Union, and if the UK government were not to track with that, we've assumed that in our model, and cost increase to over £150 million by 2025.
Right, by 2025. And can I ask, when the government spoke about the contingency planning and things like warehousing and air freight, they mentioned that the cost of that would be reimbursed by government. Have you been given any kind of indication of what how that would work and how that would actually filter down through?
None at all.
How about yourself, Mr. Thompson?
No, I believe it's still a conversation going on in government. What we'd say is that there are smaller companies who are finding this very challenging indeed.
Right, so they're not being, they could actually risk going under if it's not being reimbursed.
They just don't have a really effective cash flow when you're a small company, so these things are significant. So I do think it's in the best interest of the government to provide support for smaller companies and to ensure that there's effective warehousing available.
I think particularly unique about the medical device industry, Johnson & Johnson is kind of different in this way, but 98% of the medical device industry in the UK are SMEs.
Yes, thank you. And there may be aspects which won't be reimbursed. So, for example, you supply direct to the consumer in many cases for your products, don't you?
On our consumer side of our business,
Consumer
yes.
side of the business.
Yeah.
So will there be cost implications directly for consumers of that?
On the consumer side of business, there will be supply chain costs. So there isn't the same issue of the British Standards Institute there, but there will also be approximately a 1% tariff increase if we fall under WTO rules.
Right.
And that will be passed on to the consumer.
Now, I'm conscious lots of members want to come in, so I'm keen to bring in Martin first, if I may.
Thank you, Chair. Mr. Thompson, I think in one of your last answers, you've partly answered what I was going to come in with, because earlier you referred to the EU not being prepared to go into some detail until they'd had some substantive responses on other issues, which in effect you've now answered by saying that in actual fact they're not prepared to negotiate, they're not being particularly helpful and cooperative.
Well, I think everybody needs to put patients and public health first, and I think there are some really serious issues here which are going to impact patients across the whole of Europe. Guido Rassi, head of the really well-respected head of the European Medicines Agency, has made it clear to politicians on the continent that he believes that there will be medicine shortages on the continent. I think in that situation, I think it's really important that politicians do everything that they can do to ensure that there is an effective supply of medicines. And therefore our ask is that the EU would do the same as the UK government has done, and they would do it as soon as possible.
And you referred earlier, I think, to the fact that you were sent out a letter in December 2017 in respect of urging businesses to consider no deal. Why did you leave it until December 2017? That's 18 months after the referendum.
Well, I think a number of companies have been planning since the referendum. I think there always are those companies who, particularly smaller companies, who don't have the same resources as bigger companies. And I want to make it absolutely clear to them that our advice as a trade association is that they now needed to put significant effort into ensuring that they were planning for no deal. And therefore we wrote the letter to put that. I think we felt that was at least 15 months before a potential no deal. That was in time for almost all supply chains to be changed. But we believe that decisions had to be made then and not later.
And you also, I think it was Mr. Thompson, but others may wish to come in on this, when you were referring to the transition phase, what would be the minimum transition period that you would prefer?
I think if you ask anybody from business, that they would like to have as long a transition as possible. I think we recognise that is politically difficult. And therefore, I think what we're saying is that a transition period will make a huge difference to no deal.
Because, of course, you rightly point out the government have got political difficulties in transition, but the reality is that the public at large, and even in a constituency like mine that voted 70% for Brexit, the public are not concerned about the fine detail of a transition agreement about moving pharmaceuticals and medicines around. What they're interested in is what the headline issues were at the time of the referendum. So I think but going back to the point that you say that in effect you're saying that the EU will not, the EU 27 are sort of holding back, and quite understandably you're urging them to cooperate and fall into line with what the British government has had on offer. So it's fair to say that much of the criticism that's hurled at the government for not being able to answer these questions is actually the fault is on the other side of the channel.
Well, I think we are very grateful that Jeremy Hunter and Greg Clark wrote a letter in the Financial Times as long as July last year, making it clear that the UK government wanted continued cooperation on medicines as we exited the EU. I think that was a very clear statement. I think if you look at the Prime Minister's Mansion House speech, it's been laid out clearly there and it's been followed up in the White Paper. So I don't think the UK government could have been clearer about what they're looking for. And I think if you look at all of the stakeholders, whether it's in the research community, whether it is clinicians, I think everybody is saying this is what is in the best interest for patients and public health. So there is a real uniformity of views, and quite remarkable. I mean, my industry has got a single view for everybody in industry across the whole of Europe in terms of what we think is the best outcome. So I recognise negotiations are difficult. I would just say that we're now sort of under 6 months away from potentially a hard Brexit, and I think we are running out of time. Just to give you an example, for a company which is manufacturing medicines in the UK, they've also got to plan the supply chains of all the ingredients that come into the UK. That single company has got to revalidate over 15,000 supply chains for individual elements so that we can continue to supply those medicines to patients across the whole of the continent. I think people don't always understand that complexity that we are being faced with, and that's the challenge, and that's why a transition period is really essential.
Saffron's keen to come here, Saffron Caudry.
Yes. So I just wanted to come in on the supply chain issue, because I think it's really important that we broaden this out, actually, because it's not just about supply chain when we look at things like pharmaceuticals and medical devices. They are critically important, and I'm not saying they're not, but we have to look, the NHS is an industry in its own right, which is immense. NHS trusts are complex beasts. It employs 1 million people. It has an £87 billion budget. There are 227 NHS trusts delivering services up and down the country. We need to think of that industry as well. And I think one of the challenges we're facing is this separation between what we've got in terms of medical devices, pharmaceutical distribution, that kind of thing, and then other contracts. And it's only just now that the Department of Health and Social Care has issued a methodology for the supply chain for all of the other contracts that sit outside of those, the kind of the big beasts, as it were. And I think that we need to look at that as well, because it's the interdependence between these things. So it's about the supply of goods for capital contracts, for transport, for back office services, for IT, all of those issues as well, alongside what we think of as strictly medical. It's what it takes to run an organisation, and we need that interdependence, and we need to look at what NHS providers need, almost as an industry, and then work out from there as well. And I think at the moment, and that's not to undermine the work that's gone on here in terms of the big pillars of what's being delivered, we need to look at it from the centre outwards in terms of NHS provision and think, what do we need for NHS trusts to carry on doing their day job in the round, not contingency planning here, supply chain here, medical devices here, and that hasn't happened yet.
Right, so a coordinated
yes.
approach to it. Do any other of the panel want to come in on this point before we move on? Okay, Andrew.
Thank you. Can I just go back to the stitches which you were talking about, Dr. Lloyd Davis, and forgive me if I've not understood this properly, but I think you said Johnson & Johnson supply with 60% of the stitches used in this country. So what proportion of those stitches are made here in the UK?
So very few of them, in fact now almost zero, are actually manufactured here in the UK. They're manufactured in Mexico, but they have to receive a CE mark to be authorised to sell within the UK and within the European Union.
Right. So in the event of a no deal, they would be imported into the UK from Mexico.
Yeah.
and they currently meet British standards. So what would be the problem with having them in? Because could we not just say, well, that they already meet our standards, which were the European ones, but so I don't quite understand what would be the problem with carrying on importing them.
So they'll be imported actually into our European distribution centre based in Belgium.
Right.
Then transported across to the UK. So there'll be the EU-UK border. But the key thing is that the body that allows them to be sold in the whole of the European Union and then also the UK, the British Standards Institute, if it can't do its job by authorising, by CE marking for the European Union, then they won't receive that mark of authorisation. So they can't be sold in the UK, nor in fact in the European Union, because the body that has that power, that the UK government has said it will recognise, will have that power taken away from it if it can't CE mark from out of the UK.
Right, no, I understand that. But would it be logistically very, very challenging to have those stitches come directly into the UK and not go via Belgium?
That would be logistically possible, but we couldn't sell them without a CE mark.
Even though they would meet the British equivalent standard, that would still be a problem, would it?
Yes, because the body, the British Standards Institute, they said they haven't given an indication of doing anything but CE marking, which is the current sort of standard.
Okay, so that's, I guess, one you're turning back at us as legislators to say that would be an issue we would need to address. Can I just move on to the issue of cold chain storage? What proportion of the 37 million items of medicine that come into the UK require cold chain storage, Mr. Thompson?
So we don't have a number in terms of absolutes.
Just a rough proportion. Give us a ballpark figure.
I can tell you that half of the new medicines which were approved last year require cold chain storage.
So half of those which were approved last year.
So this is very much at the leading edge of sort of medicines which are being developed, tend to be biologics, and therefore they require cold chain. But also, if we take something like vaccines also normally need to be stored as well. So we have significant parts of our supply chain that require cold chain requirements.
And presumably cold chain storage, I've visited some of it in my own constituency, so I'm familiar with the concept, but presumably that takes longer and is more expensive to build than a standard warehouse.
Correct, which is why we are saying to government, you need to press the button now, because the ability, normally this would take longer than 6 months to build and get it signed off because it needs to be regulatory approved and authorised. I guess some of these things can be truncated, but we believe we're very much up against the deadline now.
So what's the quickest time span you could, assuming you were given planning permission, I'm
going to turn to Martin.
I think how quickly could you put up a large cold chain storage?
I think you're talking more than a year.
More than a year?
Yeah, because from my experience of pre-wholesalers building capacity, they usually plan it for about at least 2 years ahead of time. Because as Mike says, they have to have regulatory approval from the MHRA, and there's more regulations required with cold chain, as you might imagine, than ambient storage, which is above 8 degrees. Ambient storage for the stockpiling is easier because we can use capacity that isn't already being used for medicines, from other sectors perhaps.
So there's a particular issue then with the need for frictionless trade with obviously medicines which require cold storage, isn't there, I imagine, because you were saying it takes a year to build the capacity.
Yes, and indeed, because the vans themselves have to have fridges on, and of course being stuck on the side of a motorway or whatever, it's a challenge.
They might run out of generating capacity themselves, yes, okay.
Clarify, do we have sufficient capacity at the moment?
For current needs in the UK, yes.
For current needs,
yes.
But not to stockpile the extra amounts.
That is the exercise that's being undertaken at the moment by the department. We've been working very closely with them to try and ascertain what the capacity for cold chain is and whether some more cold chain can be brought on from other sectors like the food industry, for example. That's the scanning exercise that's been going on at the moment to look at capacity.
Can I just go back to Saffron Caudry on the food issue? I was just a little bit surprised to hear you say that you thought the supply of food to NHS patients might be a problem. What I've heard from the major supermarkets, they're talking about possibly price rises, and I guess there may be some delay, but I don't think anyone is thinking that food's not going to be available, are they?
I think that in the advice that's come out from the Department of Health and Social Care, they have looked at national contracts for food. So it's not just us saying it is the fact that we need to look at supplies of foods into large catering supplies. Catering contracts come under the national provision, so they will be looked at nationally in the event of a no-deal Brexit. There are also things like supported nutritional supplies, which are not quite medicines, but they are nutritional aids to patients and things like that. So there are two categories there, but they are being looked at in the scenario of a no-deal Brexit.
Okay, and that's in terms of stockpiling of dry goods, is it, or again more cold
I don't know the
capacity
detail of that.
storage?
I don't know the detail of that.
You don't know
The ongoing supply of food for large-scale catering, obviously, is an issue.
Yeah. Okay. Thank you.
Luciana, you had a point.
Yeah, I just wondered if I could get a bit more clarity on some of the questions that have already been asked, specifically about the cost of the stockpiling and also the alternative options. And the figure was put on the cost of stockpiling at around 2 billion, and I wondered whether that was accurate. And is that cost wholly being borne by industry, or have you had any support or any indication of support from government?
So I think if you look at 6 weeks of medicines, the cash value to buy the 6 weeks is about £500 million. And then you have to look at the cost of working capital that will be tied up, which will be much smaller. So, I don't know, 30 to 50 million, something like that. I think the 30 to 50 million will fall on everybody. I think for the cash, I think for smaller companies, cash is obviously a much bigger issue. And therefore, I think it's the smaller companies that we are most concerned about in terms of their ability to do what we would like them to do in terms of organising stockpiles.
I think in answer to the second part, in Matt Hancock's letter, I think of the 23rd of August, he said that the government would look at options to cover the cost of storage.
Yeah, in terms of what's happened since that letter, that was obviously 2 months ago. So
yes, and the government has continued to look at those options, and they haven't made any, as I understand it, any public decisions.
Right. Okay, and then about these alternative options that need to be considered in addition to stockpiling, because as we've heard from evidence, stockpiling alone will not be enough for some particular pharmaceuticals. Again, have you got any indication from government about what specific support they are going to extend to you to be able to carry out, whether it's the airlifting that you mentioned or any of the other options that you might be considering?
Well, I think we're at the phase where I'd expect the government now to have a good view about what stockpiling will do. I think we're in the phase now of working through what those other options are. So, for instance, 90% of medicines come in through Dover and Folkestone on roll-off lorries. There's clearly a different way of supplying the UK, which is called lift-on, lift-off, through different ports. At the moment, almost no companies have actually got that as a secure supply chain. So I think we would need some help to try and establish that as an alternative way of bringing things in. So that would need to be revalidated and worked through. We're looking at what sort of capacity is there available through airlines. Again, we do quite a lot of lifting of, say, clinical trials. Clinical trials is another good example where we can't store the medicines. So typically we would deliver those through airlines anyway. The work that's ongoing at the moment from our perspective is also to try and find out what capacity is available, recognising that in the event of a no deal, probably lots of people are going to be trying to fly things through, right? So I think there comes a time when we have to think about fast track lanes. What can we do for certain things that we want to prioritise to go through? All of that, I think, needs to be worked through. So when we get to the point where we unfortunately ended up in no deal, that those people who are on the front line had got some clear guidance about what to do so we can continue to ensure that medicines get to patients.
But as of yet, you don't have that guidance, or?
I think that's the phase that we're now moving into.
Thank you. Lisa.
Yeah, it was just a couple of follow-up points in terms of stitches and catering supplies. I was wondering, obviously we understand the short to medium term implications that you're dealing with, but over the long term, is there a possibility that manufacturing of stitches could perhaps be considered again as something the UK could be doing? And in terms of the catering supplies, most patients in hospitals would really like, local good food, and I'm wondering if then there's an opportunity in the long term to look at, in terms of self-sufficiency and using local producers a lot more in terms of those supplies.
So, in terms of manufacturing location decisions, we're consistently doing strategic reviews, where are the right places and the right locations to place manufacturing. So there's the UK, the EMEA region, they're frequently reviewed whether we place a manufacturing plant, we put it in different places. I think, in answer to a specific question about the UK, a lot of it will depend what happens as a result of the UK withdrawing from the EU and what sort of agreement or regulatory alignment is in place.
So in terms of that over the long term then, if regulatory alignment's in place, how do you see that impacting upon our ability to manufacture?
So if there is regulatory alignment or ideally mutual recognition of regulations, then it becomes easier to invest in manufacturing.
Right. And in terms of catering, what about local food producers?
It's helpful that you asked that question. Just to follow up on the answer I gave earlier, this is something that's being looked at by the Department of Health and Social Care at a national level. It's exempted from what trusts should look at for their own supply chains. Then the centre has taken hold of this one, and it says this category is being reviewed and managed centrally by DHSC. Instructions will be given to major producers of patient meals to put in place contingency arrangements to account for short supply of certain ingredients imported from the EU. Guidance will be provided to hospital caterers, procurers of patient food and catering services and PFI providers on actions to take in preparing to use substitute foodstuffs to maintain nutritional balance. So it's kind of a widespread issue here, and this won't be just about catering for hospitals. This will be any kind of mass catering. So schools, the army, the armed forces, we will be looking across the piece there. In terms of hospital catering overall, that is something where there is often local procurement, but sometimes local procurement is from companies who are themselves importing from the EU anyway, so that's local companies rather than local foodstuffs. So what we're talking about is something way down the line in terms of sourcing all food from your local area in order to supply the catering for a hospital trust. We're talking about contingency arrangements here over a period of time. We're not talking about the long-term supply, but I think that's really important to remember.
We need to look at the big picture, but I'm quite keen that we should focus for the time being on pharmaceuticals and devices. Ben, do you
The Royal Pharmaceutical Society in the Sunday Times, I think, warned that there are already shortages and that these will get worse in the event of a no deal or a hard Brexit. Mr. Sawyer, you were on the radio this morning talking about the need for the government to take emergency powers in that scenario. Could you just explain why you think that's necessary?
Yes, in the context of a no deal, if there's no deal, I think, as Saffron referred to earlier, I think we need to make use of the NHS, if you like, and command and control mechanisms, because to allow for certainty of supply of the medicines we do have in the country at that time, because remember, in a no deal scenario, we do believe the ports will be a challenge for some time. We think what medicines are in the UK should be managed more appropriately. For example, allowing pharmacists to substitute prescriptions, perhaps alternate prescriptions that were to medicines that they have available, allowing pharmacists to share and use other pharmacies' medicines, which they used to be able to do, but that they can't do that at the moment by law. So you could relax that law to allow a local community to share medicines around. And the other one I suggested this morning actually is to remove and stop all wholesale licenses for a limited time, because there's 2,500 of them out there. It allows for a lot of trading, allows for a lot of export of UK packs that should, we would want to keep in the country. Our members have 20 of those licenses, and we distribute 90% of the NHS medicines. So there's a lot of small businesses out there whose main business is not wholesaling and distribution. So if the government and the MHRA controlled it to just those businesses whose main purpose is distribution or only purpose is distribution, France has 35 wholesale licenses, and that's what they do. We have 2,500 because it allows for a free market, which has produced very, very low prices for generics. So I can't deny that, and the government saved £11 billion over 10 years. But it would be a catastrophic time, a no deal, I think, for medicine supply, and I'm not pulling any punches, and I think we have to think of emergency powers.
But this could involve patients being put on drugs, different drugs from the ones they're used to, without a consultation with their GP.
Correct.
Just finally on the stockpiling, I want to actually really nail this one down with you, Mr. Sawyer and Mr. Thompson, and ask you directly, is the current advice from the Border Delivery Group to the industry that a 6-week stockpile will be sufficient for NHS patients in the event of no deal?
That's the current advice.
That's what we've been told.
Thanks. Patients listening to this evidence might be alarmed at some of the prospects for
a no deal, potentially a catastrophic time, emergency powers, patients put on different drugs to the ones that they're prescribed. Should patients be stockpiling their own drugs?
No, I think we're here on behalf of patients. I think we're actually trying to sort this issue out and make sure politicians of all parties understand the concerns we have, because we are concerned. This is one of the last opportunities we might have to speak in this type of forum. We are very concerned as businesses. We can't plan against uncertainty. Certainly our businesses can't invest where our margins are very small. We need politicians to understand that there could be consequences of a no deal, and those are the consequences. We're not suggesting anybody needs to stockpile outside of the supply chain yet, but come January that might be a different picture, and we need to, as businesses in the supply chain, together with the government and the NHS, will have to communicate what needs to be done. But we believe, going to be in a difficult situation if there is not a deal by Christmas.
I would say from our company viewpoint, our first priority is making sure that our medical devices and technologies get to the patients and clinicians in as smooth a manner as possible. But that is, of course, going to have logistical costs and complexities associated with that, and that's what we're working on at the moment.
So I recognise the points that you raise, and certainly in my conversations with the media I ask them to be very thoughtful about how they report these issues, because I think those who are the most vulnerable in society could be particularly alarmed by that. So I think we need to be really thoughtful about this. What I'm trying to communicate is that we are doing absolutely everything in our power, and I work for an industry which I have seen do remarkable things to ensure that we get a medicine to a patient, and we have been doing that for some time now, and with the support of everybody we are looking to ensure that we do that. I think we also need to be honest with government and with Parliament to say that there are more things that need to be done in a no deal, and I think we've got to the stage of recognising that stockpiling won't be enough, and we need to put in the next phase of plans. I think the officials in the DH have done a very good job at the moment in terms of working through methodically where we are so that they can accurately manage the situation. But in some of the things that we've talked about today, I think it would be above just one department which would be required to essentially work together to ensure that government could put in place what was required to ensure a continued flow of medicines. And I think we're very close to that point now.
Thank you.
And can I just, before I come to you, Saffron, could perhaps I bring Tamara Hervey in here? Because we've heard that regulatory alignment and mutual recognition are going to be important, but in the event of no deal, how likely is it that we're going to see those in place if there's no deal and no transition?
Well, in the event of no deal, the UK can choose to align with the EU, but the EU has no obligation to choose to align with the UK. So for a complex supply chain, that doesn't help because you've got both borders in play.
Mm-hmm. Yes, so in other words, it's unrealistic to say we'll just open our borders and everything can come in, because that doesn't work for a complex supply chain. Thank you.
Right,
Saffron, you wanted to come in?
Just a point around, you were talking about stockpiling of medicines and things, but I think this takes us to a slightly broader point around contingency planning and the length of time that contingency planning should run for. So NHS trusts have been encouraged, in fact told, to use their emergency preparedness, resilience and response planning process, which is the ongoing contingency planning that they would use for any emergency scenario. And the methodology for that is good. But what that is based on is actually returning trusts to a business as usual scenario. Now we know that after a no-deal Brexit, that is an unknown. Business as usual is an unknown, and I think that's the bit that we have to be fully alive to, is that we aren't necessarily returning to business as usual. So yes, we need to do some contingency planning, but we also need to do some different scenario planning as well, because and that's why we've been asking for a set of shared assumptions so that we can understand a little more about what might unfold post the kind of 6-week period following a no-deal Brexit. But it's as one of my colleagues said, it's the period after that we need to think about.
So moving to a different system entirely.
Yeah.
Now, I'm quite keen. We've got an awful lot to get through this afternoon, and I'm just wondering, Andrew, your section on contingency planning. Did you have any further points that you wanted to raise on that? So we're going to come on to Luciana and the issue around engagement.
Thank you. Saffron, if I can. It was we saw an email exchange over the summer.
Yes.
Your organisation with the Chief Executive of NHS England and the Chief Executive of NHS Improvement. On behalf of your members, raising some concerns about contingent, a number of different things. But particularly about the lack of formal communication to trusts across our country on preparing for a no-deal Brexit. Can you share with us any progress since that letter 2 months ago?
So there has been progress since then. I think it was. I think it's fair to say that it's actually the Department of Health and Social Care's responsibility to be communicating with the sector, but we know that the central bodies, so NHS Improvement and NHS England, have a key role to play in facilitating that. It was very slow over the summer. I think it's fair to say it has now speeded up, and there have been lots of communications. However, I think one of the issues we have is that the process isn't yet fully formalised. There isn't a regular flow of information, and it's pretty piecemeal, and it goes to different places in trusts at different times. So I think what we're asking for is something that would be, regular, once or twice a week update on what is going on, going to a named person in the trust, the senior responsible officer for this particular issue in the trust, so that we know that it's absolutely being captured. And it also needs to be a two-way process. This isn't just about communication going out from the centre to trusts. That's why we're asking for NHS trust providers to be treated as an industry group for the reasons I mentioned earlier about the complexity of the organisation. So actually consult with us separately as an industry group, understand the challenges and make it an iterative process so that we don't have to keep going around all of these different loops, that we can understand together and take things forward. I think things have improved, and that's what I would want to say, that since we sent that letter on August the 17th, a week later there was some communication, one of the first communications that came out of the Department of Health and Social Care. So that is progress, and there have been a number more. I think what we need to see is it to be more coordinated, more organised.
Thank you. I mean, there was two particular areas I wanted to just press you on that it was captured in your letter, and I wonder whether you can tell us if you have now been told, or your members have now been told, about what the level of national contingency planning and support will be provided. That's the first one.
So, not yet, no, not formally. So I think where we're at on that is that there are a number of different risk planning scenarios going on. So the supply chain one I mentioned earlier has only just started, so the letter went out on the 12th of October. The responses need to be back by the 31st of November with the mitigations for the risks. That's when the national support should then kick in once they've had an opportunity to look at that. So it's about collecting all of this information, processing it, and then understanding the assumptions that people can then apply to plan on. So I would say it's a little late. It's speeding up, but it's still a little late.
I mean, just on that answer, that would then give us less than 4 months before a no-deal Brexit could become a reality. And
yes.
Is there any reason why your members haven't been contacted sooner to find out this information?
I think that the collective planning for that started over the summer rather than sooner. I don't know the reasons for that.
Okay. And then the second point was about, you asked on that in the letter in particular, was having some indication of what trusts' individual responsibilities will be. Do your members now have a clear indication of what their responsibilities are?
I don't think that this is yet clear. So this is something that we are looking at because we've got a whole host of different scenarios that come into play here. So I talked earlier about these emergency preparedness, resilience and response. That's ongoing contingency planning where trusts will put in place scenarios where they can then take control of things. But then we've got planning at a national level as well. And what we're not clear about is how those two fit together and where do national powers supersede a trust's individual powers, because a trust needs to be clear that it's not just got everything within its control fully taken care of. It needs, those interdependencies also need to come into play. So it needs to be in control of the whole picture, and that isn't yet clear. And we are concerned about that because trusts have a duty as organisations. They have a duty as companies that they can safeguard the supply of the services that they provide, and they are in a difficult position at the moment.
So we're now going to come on to reciprocal healthcare and Paul.
Tamara, Hervey, can you tell us how in the event of a no-deal Brexit, how UK citizens, including those who are either travelling to EU countries or who are resident in EU countries, will be affected by the loss of reciprocal healthcare arrangements?
Okay, so it's important to distinguish between different categories of UK nationals who are in EU countries on Brexit Day. In the event of a no-deal Brexit, all of the arrangements that we currently enjoy would disappear. So a patient who was a visitor to an EU country and was in a hospital receiving care using their EHIC card would no longer be able to rely on their EHIC card. They'd have to rely on the domestic law in the country that they were in. Now, I haven't done a comparative study of the entitlements of all across all 27 countries. All of them will recognise the basic need to emergency care. So, again, in terms of reassuring people, it's not that people will be thrown onto the streets because the EHIC card system stops functioning. For people who are long-term resident so UK nationals who are long-term residents in EU countries, they have entitlements under the EU's long-term residence directive, but that's 5-year residence. People, and their entitlements include entitlements to healthcare on the same basis as nationals of the country that they're in. It's only basic healthcare under EU law, so again you would be looking at the domestic law to know your exact entitlements, and that domestic law might not even be national law because of course some of the EU member states have devolved health systems, so then your entitlements would be different depending on which part of Spain, let's say, you were in. So one of the things that we would be facing there is a situation of extreme complexity compared to the relative simplicity now. So now there's a single system that people can understand. There's a single portal that's organised by the European Commission. You can work out what your entitlements are. It might be quite complex for some individuals to have the right paperwork even now. We'd be moving to a situation where it would be virtually impossible for individuals to understand what their entitlements were. For EU nationals coming into the UK, then we're talking about what are their entitlements going to be in domestic British law, and that, of course, depends on decisions made here about whether the relevant bits of EU law will remain the same under the EU Withdrawal Act, in which case entitlements would remain as they are now, or whether they'll be changed, and if so, how will they be changed? Will they be changed through the delegated powers that are given under the EU Withdrawal Act, in which case there are questions about scrutiny and so on? That side of the reciprocal healthcare coin is probably most important actually in terms of NHS staffing, because one of the things that makes it appealing, I'm hesitating to use that word now, bearable for people from the EU 27 to come and work in the NHS and social care sector here, is that they have entitlements to a whole bunch of things, including housing and education, but also to healthcare. And if some of those entitlements were to be changed, so for instance, if they were to be treated as ordinary third country nationals, they'd have to pay surcharges for NHS care. All of those things could be changed. They're not necessarily going to be changed. And we don't have clarity on those.
So thank you. So Saffron Caudry, what would the implication be for EU staff working within our health service, of which there are many, if their right to reciprocal healthcare were withdrawn after the 31st of March next year?
Well, I think as Tamara said, that would be a much less attractive prospect, and I think that what we are talking about here is about how we retain our EU workforce in this country, because frankly we rely, not entirely, but we do rely substantially on EU and overseas workers in our workforce. So I think that, in terms of the right to healthcare, the right to other broader benefits that's absolutely fundamental to be able to maintain the service that they provide.
And is the prospect of a no-deal Brexit perhaps weighing heavily on the mind of people? Well, I mean, what's happening, for example, to the number of nurses coming to the UK?
Some interesting trend data on that, actually. So the Nursing and Midwifery Council said that between June 2016 and March of this year, the number of new EU registrants with them is down 87%. Now, there are a number of factors in that, but one of them is obviously the uncertainty that has been caused by the potential of a no-deal Brexit.
So there's been a massive decline in the number of EU nurses coming to this country. What's the impact that? I mean, what impact is that having on nurse vacancies, for example?
Well, we've got an overall vacancy rate of around 9%, which is one of the highest that we've seen. We've got frontline vacancies of about 100, just over 100,000, which is a large vacancy rate, and proportion of that, I think it's around 10 to 15,000 nurse vacancies, but I'm not sure of that figure, so but off the top of my head. So we are looking at substantial nurse vacancies. I mean, that's just taking one workforce group. I think if you then add in, outside of my purview, but the social care workforce similarly affected by a no-deal Brexit. We've got substantial challenges there in a workforce that's already pressurised. We've never been self-sufficient in staff in the health service, and so that's a fundamental point to make. And we rely substantially on supply of nurses and doctors from the EU. And I think it's important to say that there are geographical differences here. So London, South East, Thames Valley rely much more heavily than other parts of the country do.
Thank you. May I just follow up on a couple of things that you said, Tamara, Hervey? One was that you said that if you are, for example, a UK pensioner that's been living in Spain for the last 10 years, then actually you're likely under Spanish law, depending on which region of Spain you're living in, to be able to continue to get access to most healthcare. But if you've been living there for less than 5 years, then you won't have that entitlement. Is that right?
The second part of that is right as a matter of EU law. The first part of that, that you wouldn't be entitled under EU law, even if you've been living in Spain for 10 years, to anything more than basic care. Your entitlements would depend on what the Spanish rules decide what the Spanish decided to give you. I mean, Spain obviously is important because there are many British pensioners retired in Spain, and that there were some indications from Spain that they would want to keep those British pensioners there. But the thing that concerns me is the lack of clarity. That there might be these entitlements, but there might not be these entitlements. We don't have a single no-deal preparedness notice on reciprocal healthcare. There's no information on that.
And if somebody is planning on taking a holiday next Easter, what advice should they be given? Somebody planning to take a holiday to an EU country?
Well, in the event of a no-deal Brexit, we couldn't rely on the EHIC card.
So they might be given emergency care. You've said that they would probably get emergency care, but they may well be charged for it afterwards.
They'd be treated on the same basis as, on the same basis as people from elsewhere in the world, not from the EU, depending on where they were going. The practical advice to everybody will be to take out health insurance, and certainly this committee heard evidence to that effect, and so did the House of Lords Committee.
My understanding of health insurance is that if you've got a pre-existing condition, then your health insurance might be much higher. So in the event of a no-deal Brexit, there will be people who have health problems who wouldn't be able to get insurance to travel to, or would have to pay phenomenal amounts of money in order to travel to Europe.
Yes, again, the House of Lords inquiry on reciprocal healthcare found that there would be some people who wouldn't be able to access insurance in terms of the products that are currently available.
We've got the Secretary of State coming along in the next panel. Are there any questions you'd like us to ask him about contingency planning over reciprocal healthcare?
Over reciprocal healthcare? Yeah. I mean, I think there are a number of factors that we need to take in with reciprocal healthcare, because it's not simply about the impact of whether people will be treated in one country or another. a no-deal Brexit could also lead to a large number of expat pensioners, for example, returning to this country, and this is another issue. There's about 190,000 of those, and I read some figures that basically said it would probably, if we were to incorporate them into our health and social care system and treat them, it would probably cost us around £500 million. So it's worth bearing in mind that it's not just about whether you could be treated in one country or another. There are other knock-on impacts of that. Also issues like, it's currently part of our referral process that you can refer people to other EU countries to be treated. That would potentially be taken out of the tools in our box, as it were, to treat people.
Can I reply to that? I would suggest that you ask whether, because there haven't been any notices on this, have there been any assurances from the EU that in the event of a no-deal Brexit, arrangements for reciprocal healthcare will be made?
And just to follow on from that point, the situation on the island of Ireland, where patients are used to being treated either side of the border, are you aware of any assurances that have been given about the position of those patients who travel from one side of the border to the other for treatment? In the event of a no-deal Brexit?
The situation on the island of Ireland will be covered by the common travel area arrangements and the constitutional relationship between the UK and Ireland and the people who live in Northern Ireland. The specific challenges for health, again, I haven't seen anything outlining this in any detail. There are questions not just about people crossing the border, but also about products crossing the border.
Yes, because one of the issues being raised for us is that if somebody from the EU accesses treatment in the UK, we would continue to offer treatment. There wouldn't be any mechanism for then for reclaiming the money from the state that they came from, because that currently is that's correct. In the event of a no-deal Brexit, there will be no mechanism for the UK to reclaim those costs. So another question that could be asked of government is there an intention to change retained EU law that entitles incoming patients to that treatment, because we will be in a situation of paying for it but not being able to recoup it? Yes.
And if so, how is that change going to be made? How is it going to be scrutinised? All of the questions that follow.
Thank you. I know Andrew and then Lisa, we're going to move on to...
Just a small question to Saffron Quadri. The Secretary of State told Parliament this morning that there are 4,000 more EU nationals working in the NHS and social care since the referendum overall. So I just wondered which areas have gone up, if nursing's gone down.
I don't know the answer to that question specifically.
You're not sure? Okay, we'll put it to the Secretary of State later.
Yeah.
All right, thank you.
Thank you. Lisa.
Some of my questions have already sort of been addressed, but in terms of workforce, what assessment have health and social care services, particularly those that are heavily reliant upon EU nationals, made of their ability to maintain service delivery in the event of a no deal?
So, I mean, this is essentially around workforce, and obviously workforce has been a massively challenged area for the NHS even before the EU referendum. So I think this is a compounding factor. So essentially, we know that the NHS is a long way from being self-sufficient. It is putting in place as many contingency plans as possible, which is about looking at recruiting staff from other places beyond the EU. So that means, overseas from other countries outside of the European Economic Area. But obviously that isn't that straightforward, because when you factor in immigration rules and migration rules, then there isn't an untapped supply. There are limits, although the limits have been removed for doctors and nurses, but we're also talking about healthcare assistants, we're also talking about social care workers and things like that. So it's a challenging scenario, and one of the things that I think comes up with this is we were talking earlier about the additional costs of a no-deal Brexit, and one of the things that may well happen as the supply of EU workers dries up is that we rely more and more on agency staff, and that's one of the areas where we've been trying very, very hard to cut down our spending. So, we are in a situation here where in the short to medium term, we need to look very carefully at that. Now, obviously, we can increase training places, and that can be done, but that's, training takes 3 years, 5 years, 7 years. So that's one of the issues.
Mm-hmm. In terms of posts such as healthcare assistants and social care, could we be doing a lot more in terms of increasing self-sufficiency in order to meet the demand?
There are lots of initiatives underway, things like apprenticeships, things like the nursing assistants and those kind of roles. But essentially, we have to, over the medium term, we have to make nursing, healthcare, social care a much more attractive profession for people to come into in order to encourage them to do that. And that then ties into a whole host of other issues around terms and conditions, pressures on the frontline staff, and that whole web of issues, which I won't get into now because I know there isn't time.
There's not really the focus of our inquiry today, looking at the existing...
But those are the factors that we would need to take into account. So
Yes.
it's a longer term issue to make us self-sufficient.
Okay. And in terms of the settled status scheme, which the government announced will apply in the event of a no deal, do you have any concerns about that scheme and how it's going to be implemented?
I think that one of the issues we've had so far has been the uncertainty around settled status. We are just now getting to the point where there is a pilot running now, or it's about to start on the 1st of November and run through to the 21st of December for all NHS and social care staff to look at them actually verifying their settled status through the digital routes. There are some issues with that. It doesn't work on Apple, it only works on Android. It's a technical issue, but it's quite a big one actually. So NHS trusts are thinking about how they can manage that in terms of, potentially Android devices that people can use if they don't have them. But essentially, that is something that we do really need to think about. And I would say that settled status has been an issue that we've been discussing from 2 to 3 months after the EU referendum, and it's taken an awfully long time to get us to this point where we're just piloting for health and social care staff only the settled status application process. That uncertainty has been very, very challenging for people.
Time is very limited, so we're going to have to move on to our final section on public health. And Rosie.
Right. In that case, we'll truncate this a bit. I suppose we've heard some details of potentially catastrophic situations in the evidence so far. But in public health, I want to move to a more general view, which there's been considerable progress in public health, and the EU has a duty of do no harm. The government have very clearly said that they guarantee no rollback on the progress that we've made. So I suppose to encapsulate my question is, really, what do you see the key risks to public health are, and how confident are you the public health standards in a no deal scenario will be protected?
Yeah. I think that there are a number of issues here. One of the things that I think we probably all recognise the EU for in terms of public health is around communicable diseases and tracking the flow of communicable diseases. And we know that being a member of the EU, we benefit from early warning on those issues. So I don't know what the scenario will be in terms of those networks for early warning, and some of my colleagues might know the answer to that. But that is certainly one area where I think we need to be very careful, because that's how we anticipate what's going to be coming down the track.
I mean, I can speak to that. In the event of a no-deal Brexit, the UK will immediately be excluded from the European Centre for Disease Control.
Yeah.
The Faculty of Public Health has issued a document, with I think 64 other organisations, has issued a document setting out what the preferred outcomes would be. The number one preferred outcome is to be a full member of the ECDC, and they've calculated the cost of that. Alternatives include negotiating a bespoke Switzerland-type arrangement with the ECDC. Time will not be on our side for that. And I think the third option is some kind of bilateral arrangements with the ECDC, the international health regulations, and so on. In the event of a no-deal Brexit, there will be a period of time before any of those things have been done. And during that period of time, logically, we would not have the benefit of the information that comes through those systems.
So basically, we have no confidence that those standards won't roll back.
It's very difficult to see how the undertaking that the government has given to do no harm could be fulfilled in the event of a no-deal Brexit.
Very, very scary.
Thank you. Well, I'd just like to say thank you to all of you for coming this afternoon and for bearing with us while we had a long pause in the proceedings this afternoon. Thank you. And is there any other points that you feel that you would like to give us some further evidence? Please do send that to us. Thank you very much.